In this video, we're going to be talking about the management of diabetic ketoacidosis and hyperosmolar hyperglycemic syndrome, two complications of diabetes. I'm going to go over a little bit of pathology, a little bit of biochemistry, and the management. So we all know that diabetes usually means little to no insulin, and as a result, you have all this hyperglycemia, glucose that can't get inside cells, so the cells are functionally deprived of glucose. As a result, you're going to have an increase in glucagon and epinephrine to increase your glycogenolysis, gluconeogenesis, and stop the glycolysis. So functionally speaking, the TCA cycle, which generates energy, will be halted. One of the intermediates of the citric acid cycle is oxaloacetate. Oxaloacetate can be shunted to make glucose, and if your body continuously tries to make glucose from this intermediate, as a result, you're going to have a drop in oxaloacetate. The other thing the body does to compensate is to increase the breakdown of fats and sometimes protein as well. Focusing on the fatty acid breakdown, so your triglycerides, your fat stores are broken down by an enzyme called hormone-sensitive lipase. That breaks down the triglycerides into glycerol, which goes to the liver, which can be converted to glucose by the process of gluconeogenesis. And the fatty acids, which are transported by albumin, undergo beta oxidation, and that gives you some energy intermediates like NADH, FADH2, and very important, acetyl-CoA. All this acetyl-CoA becomes a means of energy production because it could be fueled into the citric acid cycle. But what happens is that there's so much acetyl-CoA being produced that it overwhelms this cycle. So all that excess acetyl-CoA is turned into acetoacetate, the first ketone body. From that, you get your beta-hydroxybutyrate, and then you also get acetone, which is exhaled and gives you the fruity breath of DKA. In addition to glucose, the brain, muscle, heart tissue, they can use ketones to generate energy, and that's where this beta-hydroxybutyrate goes. Okay, so the takeaway points: diabetes, low or zero insulin. There is all the sugar in the body that the body cannot use, so it's like a functional hyperglycemia. What does the body do? It increases glucagon, epinephrine to increase gluconeogenesis and glycogenolysis to get some glucose, make some energy. Fatty acids are broken down, the products of which are glycerol, which goes to the liver to make glucose, and fatty acids, which undergo beta oxidation and make acetyl-CoA. The acetyl-CoA can be used to fuel the citric acid cycle, but there's so much of it that it overwhelms the cycle, and some of it is shunted into ketogenesis, and you get your acetoacetate, which is turned into beta-hydroxybutyrate and acetone. So now that we know what's going on at a biochemical level, let's talk about the different spectrums of this hyperglycemia between DKA and HHS, and that's how I like to look at it, two different spectrums of a kind of a hyperglycemic state. So DKA is more common in type 1 diabetics. They're younger patients. HHS is more common in older patients with type 2 diabetes. So when I think of DKA, I think of no insulin. When I think of HHS, I think of maybe a little bit of insulin, but it's not doing its job. There's insulin resistance, but it's there. In type 2 diabetes, when you have insulin resistance, the pancreas bumps up the insulin production, but later in the disease, you get no insulin. So that's kind of why I see these two disorders on a spectrum where there could be some overlapping lab values and clinical findings. I know clinically might be some like gray area between the two, but board questions are a lot more black and white. Really helpful way of differentiating the two on board questions at least is the presence of beta-hydroxybutyrate and metabolic acidosis. So like I was saying, DKA, no insulin. Body tries to make its own glucose. You end up with all that acetyl-CoA that we talked about in the biochemistry, and that's shunted to make some ketones, okay? HHS, there is still some insulin there, so that's why you don't get that ketogenesis with HHS. With that ketogenesis, you're going to have a high anion gap, metabolic acidosis. With DKA, you do not have that with HHS. The main problem with HHS is insulin resistance and dehydration. So you're going to have decrease in volume. All that glucose will give you osmotic diuresis. That's going to increase the osmolarity, and that is going to give you altered mental status because that affects the fluid distribution in the brain. So the osmolarity is going to be elevated in HHS. It's going to be more or less normal in DKA. The potassium and sodium are two electrolytes that are also affected. The potassium could be elevated or normal or even low, but you just have to understand that the total body potassium is decreased because of the intracellular shift because of the acidosis and lack of insulin. The tricky one is sodium. So when you think dehydration, you think hypernatremia, right? All that glucose that's floating around the body dilutes the sodium by shifting the intracellular and extracellular fluid. So you have to correct the sodium. For every 100 mg per deciliter above normal, you have to increase the sodium by 2. Other thing ketones do is that they cause a leukocytosis. So if you're looking for an infection, the white count is not the best indicator. You should check out the differential for bands. When these hyperglycemic patients come to the hospital, they get a UA to look for ketones in the urine. The chemical process that detects that is called the nitroproside reaction. That only detects the acetoacetate in the urine. It does not detect the beta-hydroxybutyrate. Therefore, you can't use the presence or absence of ketones in the urine to make your diagnosis. You have to use beta-hydroxybutyrate, which will be found with a blood test, not in the urine. Kind of a summary picture that should help you navigate through questions. So let's review. So DKA, the pancreatic beta cells make no insulin. More common in type 1 diabetics, could even be the presenting symptom. Younger patients, no insulin. Normal osmolarity, the anion gap will be elevated because of the ketogenesis. That increase in epinephrine is going to give you abdominal pain, nausea, vomiting, and your bicarb is going to be low, less than 18, because of the acidosis. And HHS, on the other hand, the issue here is super high glucose, dehydration, you have some insulin resistance. Early in the disease, the pancreas increases insulin production to compensate for that resistance, but later that insulin production goes down. Altered mental status should really be a useful differentiating factor between HHS and DKA. That dehydration and fluid shift, increased osmolarity, that gives you the altered mental status. Again, there's no ketogenesis, there's no anion gap. One thing I never really understood was why the glucose level in HHS was like in the thousands, and for DKA it was like 250 to 300. So remember when I said the DKA patients are usually younger? So in diabetes, early in the disease, there's a period of hyperfiltration where your GFR actually increases. And because their GFR increases, they're able to get rid of more glucose in their urine. On the other hand, the HHS patients are usually at the end of the disease. They're like really bad diabetics who have insulin resistance, and they're usually older. So these patients have a significant decrease in GFR, and therefore they're not able to get rid of glucose in their urine, as well as the younger patients with DKA. Treatment of DKA and HHS focuses on 3 things: IV fluids, lights, and bicarb, and insulin. Now, the management of DKA and HHS is a little bit different from each other, but it's pretty similar and revolves around these 3 things. So the first thing you want to do is you want to assess the volume status. If they're super dehydrated, you would hit them with some normal saline, 1 liter per hour. If the patient is moderately dehydrated and you don't feel like they need a whole liter of normal saline, check their sodium. If they're hypernatremic, you can give them half normal saline at about 200 to 500 an hour. And if they're hyponatremic, just give them normal saline at the same rate. When the glucose reaches 200 for DKA and 300 for HHS, you can change the fluid to D5 half NS at about 150 to 200 milliliters an hour. Moving on to the electrolytes and bicarb. Now, the potassium, sodium, and bicarb are the main things you should be focusing on. The other really important electrolyte is phosphate that I'm going to talk about in a little bit. If the patient is super hypokalemic, less than 3.5, hit them with 20 or 40 milliequivalents IV. If they're in that middle range, 3.5 to 5.5, you can usually get away with adding 20 to 40 milliequivalents in the IV fluids that you just chose. If they're hyperkalemic, you can usually hold off and not give any potassium, but with DKA patients, you check labs every 2 to 3 hours and just continue to assess the potassium as you go. So the sodium is usually low, and that's pseudo-hyponatremia. The reason for that is because of the intracellular shift of water that dilutes the sodium. So you want to correct it. For every 100 milligrams per deciliter above the normal, you should add about 1.5 to 2 to what the sodium is. After that, if they're still hyponatremic, you can give normal saline. If they're normal or slightly elevated, you can give like half NS, and the rate is like 250 to 500 milliliters an hour. Don't give bicarb unless the pH is less than 6.3. If so, give them 1 to 2 amps of bicarb with 20 milliequivalents of K. Now let's talk about the insulin. So In uncomplicated DKA, you can sometimes get away with giving them sub-Q insulin, usually like 0.3 units per kilogram times one dose, and then you hit them with 0.2 units per kilogram for the first hour. And if you can't give them sub-Q, most oftentimes these patients get IV insulin, and the dosing for that is 0.1 units per kilogram, followed by a continuous infusion of 0.1 units per kilogram per hour. So the goal is to kind of get it to drop within like 50 to 70 in the first hour. If you've achieved that, dope. If you haven't, you should probably double the dose that you hit them with in the beginning. So let's say that we've successfully dropped the glucose, by 50 to 70 in that first hour. Here's where the treatments kind of diverge a little bit. In HHS, if you've achieved that drop in the first hour, once the glucose is 300, you want to decrease the infusion by 0.02 to 0.05 units per kilogram per hour. On the other hand, if you're a DKA patient and the glucose dropped adequately the first hour, the next thing is that you want to, once the range is at 200, the glucose is at 200, you can do the same thing. You can decrease the drip by 0.02 to 0.05 units per milligram per hour. Or alternatively, you can just start giving them some sub-Q insulin. So once you've decreased the drip for the HHS patients, you want to keep the glucose within 150 to 200, and until they are mentally alert. That's very important. And for DKA patients, you want to keep the glucose between 150 to 200 until the DKA resolved. And what that means is when the anion gap has closed. After that, you can usually transition both patients to sub-Q insulin, but the prerequisite for that is they have to be able to eat. I've always found transitioning to sub-Q insulin after a drip to be a little challenging, but generally you want to calculate their total insulin for the day. If they're insulin naive, you can usually do like 0.5 to 0.8 kilograms per day. Depending on how much they're able to tolerate a diet, I'll either decrease that a little bit more, or I'll increase it if they're like eating a lot. What I found was helpful was that, the nurses would document how much insulin the drip was running at every hour. So I would calculate it for 24 hours to get an idea of how much they need in a day, instead of using that formula. And I would either do like 50-50, 60-40 between the basal and bolus and adjust accordingly. It's important to keep the drip running for about 2 hours while you transition them. So these patients are getting blood work done about 2 to 3 hours. The main thing you're checking is a metabolic panel, so lights, BUN glucose, venous pH, beta hydroxybutyrate, and of course you want to make sure the anion gap closes. In addition to that, you want to figure out why this happened. Was it an infection? Was it non-compliance, alcohol, starvation, etc.? Another electrolyte I didn't really talk about was phosphate. A lot of people say that you shouldn't supplement the phosphate unless it's very low, like below 1. My attending once told me a story about how very low potassium precluded successful extubation. After all, potassium is one of the elements in ATP. Yeah, that's all I got for this video. Please let me know if you thought this was helpful and if I should make any more videos. If I made any mistakes or if I didn't cover anything, let me know. Thanks.